Well, thank you, everybody, and thanks for joining us today. We already have almost 60 participants, and I'm Dr. Jorge Calzada, and I'm joined by Dr. Glenn Yu and Dr. Brian Horseman from California and Phoenix, respectively. We're three different people from three different sort of practices. I would think I'm in the solo private practice. Dr. Yu is an academic practice, and Dr. Horseman is in a large ophthalmology practice, and we have different experiences in our approach to micropulse laser therapy for macular diseases. And we're here to talk a little bit about this and our how we work on this. So thanks everybody, and we're welcome to begin whenever you're ready. Rigo, just tell me when you're ready for me to start.
Yep, we are ready.
Perfect. So I'm gonna share my screen. Is everybody capable of seeing me here? Okay, let me see. And here we are. So, as I said, I'm Dr. Jorge Calzada. I founded my practice, Deep Blue Retina, here in the South. And I'm going to be talking about micropulse laser for macular edema. As I said, we all of us have different approaches to how to utilize this technology, and I wanted to basically talk about my personal experience with how I got to micropulse therapy. In terms of disclosure, these are some of the companies that I work with, and so what is my story? Because I think that there's always a technical engineering part, and then when you introduce these sort of therapies for your practice, there's a personal story, and I wanted to share one. So it all began with a significant level of skepticism and inexperience. And for those that have followed me on social media, I'll tell you how I handle things. And you may have noticed that I never, 2 years ago, discussed micropulse laser therapy. And now I'm actually very, very happy with it. And to the point that I'm presenting in this webinar, my experience with laser was mostly standard, continuous wave laser for standard pigmental photocoagulation, retinopexies. And I think we all have experience with the old trials in macular edema, the CSME sort of determination of diagnosis. But I think with all the knowledge that we have and experience with anti-VEGF therapies, and to some degree steroids, most of us have migrated from the old laser therapy to injectable therapy for macular degeneration, for macular edema, and RVOs and diabetes. But then the question is, what's this role for MicroPulse? So I've been utilizing MicroPulse for the last 2 years, and I first dipped my big toe on it, and based on getting results that were frankly better than I expected, I started moving along more and more and increasing my utilization with this, and that's my story. So currently, I use it fairly frequently on selected patients. I still don't use it on everybody, and I'm developing my own treatment protocols. And when you hear the other physicians on the panel, for example, Dr. Horseman has significant experience, certainly much more than mine, and it's a different approach on how to do these things. So those that are involved in the treatment of macular edema are used to knowing about the different options for treatment. We have all the different anti-VEGF therapies, and we can add medications to this list if we so want to. For the anti-VEGF world, the steroids, whether injectable standard steroids or implants, Ozurdex or Iluvien. I'll talk about NSAIDs in a little bit, or what about vitrectomy surgery? Then there's traditional macular grid laser, as I said, the old timey laser, and micropulse laser. So these are all the options that we have, and where do we use everything? So let me just go back before we approach the question and say, why would we even consider micropulse? Because I think we all know that we have really good results with our current injectable therapies. And I'll make this point on one of the patients earlier, but we talk about the burden of injections. And the burden of injections is a combination of burden of injections and burden of visits, increasing risk of endophthalmitis with multiple injections. Uh, but even on the best of patients, non-compliance is an issue. And by non-compliance, I mean continuing therapy for a long time without an end date is very difficult for even the best of patients because, as I put here, coexisting disease. I always say a standard patient that falls for injections every month or so, then falls and breaks her hip and just can't come to clinic. And then by the time they come, the disease that you've so hard, made an effort to manage now it's worse. There's another benefit to our clinics, and it is these two issues about pharmacological inventory management. All this issue that we have that effectively we've become good at, but not because we ever wanted to be, in this issue of inventory management for a minuscule financial benefit for our clinics. And particularly when you add this sort of reimbursement complexity of multiple J codes and how do you order and when do you pay. And so clinics are burdened with with the pharmacotherapy, and patients are burdened with medications that we inject, even though they work and they're great. Um, so going back to another question that is important is MicroPulse different from traditional laser or continuous wave laser? And it is. So standard laser has, if you say a duration of time, say 100 milliseconds, the laser will fire through that whole time. In MicroPulse, the whole point is that the short bursts, and we measure them in percentage of duty cycle, short bursts in the duration of the whole exposure. And from a biological perspective, this is at least the way that I understand it. And perhaps there's people who understand it better than me, but it's about thermal diffusion from the point of laser. Because when you have a uh, the photosensitizing effect on the molecules that are accepting usually melanin, uh, as the temperature in the spot rises, the longer duration that spot will increase the thermal diffusion around it and will cause apoptosis of cells around it. So therefore, it is a reasonable physical concept to decrease the amount of thermal duration of energy. But nevertheless, even though it makes sense from a physics perspective, uh, I will admit I was very skeptical at first. I was trained and worked for a year, I mean, for a decade, I'm sorry, without using micropulse laser, using a standard continuous wave laser. And when I had my hands on the first machine, I said, I wonder if this is just sort of mumbo jumbo that says something. And one of the problems that I had is when I spoke to people, they say, well, you can laser through the fovea and you will never see an effect. And my brain said, well, this doesn't make any sense. In the question that I asked, how could there be a biological effect in the absence of an objective, demonstrable effect that you can at least see on imaging or some form of finding? And to me, it led to me to just kind of like, should I bring sage around the patient? I want to make sure that something happens. If something happens, I believe that there's an effect. So some of my first patients, I started realizing that there was something happening. And so I'm sharing you this patient here. This is 1 month after a micropulse laser for non-foveal involving macular edema. And if you look closely, so this is pre-laser and this is post-laser. And as you can see here, again, there's pre-laser, there's a foveal cyst with some edema adjacent to it. This is 1 month, so the laser hasn't gotten its full effect. So there's still a foveal cyst. The edema hasn't improved. But I want to point to this area right here where you see these hyperreflective spots on infrared imaging. And these are a direct cause of the laser. And even though the laser, you could not see this on direct ophthalmoscopy, and you cannot really see it on OCT, you can definitely see it on the infrared hyperreflective spots or hyperintense spots on infrared imaging. And to me, this was perhaps that sort of way to say, okay, there is a biological effect that I can recognize on imaging, and therefore there I am willing to see this through. And of course, you start seeing patients with the decrease in macular edema. So to me, it's on that breakthrough for me was perhaps the important part to just start moving away from the skepticism. So Dr. Yu will talk about this in a second, but the way I look at this, there's really two approaches for micropulse laser when you're dealing with macular edema. One is when you have diffuse macular edema, broad severe macular edema, that you know that you're going to require some form of injection therapy, whether it's anti-VEGF or steroids or a combination of the above. And your intention is to reduce the injection burden. So not necessarily to replace injection therapy, pharmacological therapy, but at least reduce the burden. But then there's another option, which is the one that I'm going to be sort of focusing on today, which is monotherapy for focal macular edema. Because the way I look at this, diffuse macular edema, when you consider reduction of injection burden, it's a statistical question, and that requires significant studies to demonstrate the burden of injection and the change, and it's it requires statistics to prove. For macular edema, when you see monotherapy, I think to me that's a clean sort of finding that really demonstrates the benefit of this therapy on a patient like this, for example. So this patient, another diabetic. Again, I practice in Memphis, and we have a clinic in Mississippi, so we have diabetic patients galore. And you have this pretty significant macular edema, just basically reaching the fovea, but mostly extrafoveal, the foveal involvement, but not completely diffused throughout all the quadrants. And based on these previous experiences that I've showed you, I proceeded to do MicroPulse laser. And this is the second follow-up visit. And when you see 1 year post therapy, you see complete resolution of the macular edema on this patient in a way that, frankly, I would have not expected. And this is in the absence of adjuvant pharmacological therapy. Um, I find this very, very compelling. And to me, this is one of the reasons why I have now instituted these therapies more in my clinic. And then the question now is, where do you approach it? So that the way I look at it is, if I have 1/4, so if you see the ETDRS grid, if the burden of edema, as you see here, even though this is approximately 1/4 this area for all if it's here, 1/4 or less of the ETDRS grid, I think is a really good approach for using MicroPulse laser as a thought. Um, this is a similar patient, as I said, less than 1/4 grid, treated with monotherapy with MicroPulse laser with complete resolution of the macular edema. Now, this patient in particular, I find very important because this patient has neovascular glaucoma in the other eye, has had a vitrectomy with endo-PRP in the other eye. The other eye has poor vision. So this patient had good central vision, but obviously edema that was coming close to the fovea. And I decided to treat with MicroPulse laser. What happened to this patient? This patient developed liver cancer in the intervening 1.5 years between this point and this point. He developed liver cancer, had to have a major surgery for his liver. And this is a great compliant patient that I failed to see for like 8 months with complete resolution of disease. If I had to use some anti-VEGF therapy, I can guarantee you that the improvement would have been short-lived. There's another point of this, which there's the point number one is compliance or non-compliance in long duration therapy. The other one is kinetics. When you're used to using anti-VEGF therapy, you're used to having a quick response, like within weeks. So MicroPulse laser does not work that way. Even though I've shown you a patient that improved in a month, the majority of patients will improve over the course of 3, 4, 5, 6 months, and sort of a gradual process. And you need to know about that. So in terms of my settings, and everybody has their own different sort of a recipe for their home cooking, but this is the one that I use. As I said, this laser, the Iridex IQ 577 is a 577 wavelength. I use 100 microns spot size for the duration of 100 milliseconds. But remember that since we're doing MicroPulse, this 5% duty cycle of MicroPulse means that the laser is not really doing 100 milliseconds. It's actually 5 millisecond total duration of over the 100 millisecond timeline. I do titrate the power. I know that Dr. Horstman has a different approach to this, but what I do is with a 100 millisecond spot and 100 micron spot, I go near the arcades and I basically titrate the power to barely perceptible white spots, barely perceptible gray. And then I go 50% of that. So usually the power comes to around 500 to 700 milliwatts, which is interesting. This feels higher than what you're used to using on your continuous wave laser, and that's to be expected because you're delivering a significant less dose of energy power. I use a grid 3x3, so I think Dr. Yu uses a larger grid. The reason I like the smaller grid is because I find that patients move while I'm doing their spots. And so I prefer to do 3 by 3 so that they move that much. And an important question is what area to treat. So whenever I'm treating, I put up the patient's OCT and angiography where I can see it adjacent to the laser. And I usually treat both the area of edema on the OCT and in the area of leakage on IVFA. Usually these overlap, perhaps may not overlap completely, but these are the areas that I intend to treat. And as I said earlier, these are the options for macular edema. But when you think through this a little bit better, you realize a traditional macular grid laser is very few people do it normally nowadays because of its, the outcomes and bad outcomes that we have. Not bad, but the lack of response to this. Topical NSAIDs should be removed from this list as well. I bring them up because I see a lot of patients being treated, but the truth of the matter is that on these chronic vascular conditions, this is not inflammatory conditions. It's different when you have a post-cataract surgery DME that worsens. I can see topical NSAIDs in that situation, but I don't think it's at all the mainstay of therapy. I think most of us will agree that the mainstay of therapy still remains anti-VEGF therapy, with steroids being perhaps an adjuvant therapy, knowing full well that it has effects with intraocular pressure or cataract. Vitrectomy surgery still has to be considered for patients with epiretinal members or macular traction. But this is the point. MicroPulse laser, in my perspective, is the only non-pharmacological, minimally invasive, long-term therapy that we have available for macular edema, and therefore I have approached it in my armamentarium, and frankly, I'm using it more and more because of these reasons. And you guys that don't follow me on Instagram, please follow me. I'm Jordi called Retina, and we'll be presenting more cases and more discussions on social media as we go. And now I'll pass it to the next panelist. Thank you.
So my name is Dr. Brian Horstman. I've been doing MicroPulse laser for close to 18 years. My first introduction to this came from 2 days really of conversations, probably 5-6 hours a day with Giorgio Durin at an ASRS meeting in San Diego, and he presented his interest and his work and some of the physics. His a very well-established physics background, very bright guy who explained to me the concept of doing laser that does not leave a visible mark. And at that time, I was in the same camp as Dr. Calzada. It took me probably a day and a half even to get my head around this concept that this was even possibly a good idea. I went back to my practice in Phoenix. It took some time to actually purchase a laser from Iridex. In those days, it was strictly the MicroPulse that was 8-10 nanometers, the far infrared. I've been very impressed by all of the lasers that I've had from Iridex over the past close to 25 years. I'd actually used one in Canada for a short time that was on loan. These way back in the early days of the late 90s when some of these lasers were available. So the slide that you're seeing now, the laser parameters, I do stay with the fixed parameters. I do not alter them for any reason. Power is around 500 milliwatts exposures. You can see all the numbers there. One really important concept is the duty cycle. The duty cycle stays at 5%. An absolute rule that is never to be disobeyed in the macula. If you're doing work outside the arcades, be it a diabetic for a MicroPulse PRP concept or some other reason, then it's permissible to go up to 15%, but that should not happen in the macula. Delivery time takes about 2.5 minutes. The number of shots is critical here because the concept of low intensity, which MicroPulse laser is, and high density is really, really important. It's like carpet bombing the macula. I do treat through the fovea. I think everybody does that uses MicroPulse correctly. There is absolutely no signs of damage on fundus autofluorescence, on fluorescent angiogram, on ICG, which I do frequently, or on microperimetry. The power is fixed. I don't titrate for a variety of reasons. I have no problem with those that do. There's more than one way to deliver medical care, and one learns as the hair disappears and the hair becomes gray that there is no one fixed answer. So someone like Dr. Cazaldo, who's extremely careful and is looking after the numbers, I think that's it's as good as anything that can be done. This is very simple for those that's getting started. You don't have to worry, am I doing enough? Do I do 50%? How gray is a gray burn, et cetera? Those are things that can be problems. And from the American National Standards Institute some time ago has established the concept of MPE, maximal permissible exposure. And what that works out to be, if you do a visible burn, barely visible to the human eye from a laser application, 1/10 of the visible application is supposed to be absolutely impossible to cause damage to the pigment epithelium. And that's where the laser effect is occurring. And from there, you get transfusion of other effects that affects blood vessels, an incredible number of vascular inflammatory markers are downregulated by doing MicroPulse. And what's really important is heat shock proteins go up, and they're maintained for some time. Most of this data comes from, all this data comes from cell culture lines. So I'm not aware of anybody who's measured this clinically. It certainly would be a difficult problem and very interesting problem. And the last issue I want to talk about is that I do 2 delivery systems. One room has a slit lamp adapter. And I found an old transequator Volk lens that I bought many years ago, and I tried to find another one as a replacement or for my second room, and I can't find one. So if you can get your hands on this, it saves putting coupling fluid on the macula, on the cornea, beg your pardon. And a lot of patients don't like that kind of gooey feeling, even if you irrigate afterward. The second room, I have a second MicroPulse laser with an indirect ophthalmoscope attachment. My lasers are 577 nanometer yellow. The indirect works really well for a lot of elderly patients that have difficulty holding still, difficulty with positioning. You can recline them, you can make their necks comfortable if they have cervical disease, which many people do. There are a number of people that simply are just not tolerant of contact lenses. That creates anxiety. That if you can avoid that, it's very nice. I have one room with a cordless Bluetooth foot pedal. That is a lovely addition, and a second remote that you can see on the left side of the picture. It just makes it easier to avoid cords. I find in ophthalmology that we're constantly tripping over cords everywhere we go, clinic, OR, we just can't get rid of these things. The use of MicroPulse laser in macular degeneration is one of my primary interests, although I do it for really all comers in terms of macular vascular disease. Those that have wet AMD with confirmed choroidal neovascularization, and confirmation in my clinic involves a fluorescein, an OCT, obviously. ICG I do on every patient. I have at Heidelberg, which gives you a video. So ICG in still form, in my experience, has been very difficult to interpret. The video ICG is excellent at finding so-called occult membranes. In many cases, they're not occult at all. You just have to learn what to look for, and the video ICG can be really helpful with that. I found that I initially treat with an anti-VEGF of my choice, typically Avastin. If I move up to a more expensive drug, it typically is Eylea. The response rate is good for about 20% of people are really well controlled from the early days, especially if they come in with decent vision and not incredible amounts of fluid and RP, early fibrosis. Of these 20%, they have all had MicroPulse laser by 1 month out. And I'll see them back at that 1 month, repeat the angiograms, look at the OCT, talk about their vision. And in my experience, I would say about 1/5 of patients do extremely well. And you may need no more than 1 or 2 or maximum 3 injections. And you can carry them thereafter by doing quarterly MicroPulse laser. And that's all they need. I have patients that have been 2, 3, and 5 years without an injection after initial presentation. The bulk of the group in the middle, of course, there's always those, about 60% require ongoing anti-VEGF injection. My typical numbers are about 4 injections a year. All these patients are receiving MicroPulse laser every 4 months. And I've experienced a dramatic drop in necessary injections in these patients. Control is good. Their vision tends to stay whatever it was when they first presented. As you know, very few have improvement. Those that do are a nice feeling and a great home run. And the last group, which troubles us all, is that 20% that presents with early submacular fibrosis. You can see it on the OCT. And there are findings on the fluorescein that help you too. These people seem to have an inexorable loss of vision down to 2200 with this well-established submacular fibrosis. Sometimes it takes 6 months to a year to get there. Sadly, nothing really works well for this group. Further injections after 2200 has been reached is probably pointless. The important thing about these poor responders, and the fact the 60% that present with unilateral disease, is the other eye. 99.9% will have findings of so-called dry macular degeneration. And those people require, and in fact, you can do rescue therapy by doing, again, quarterly applications of MicroPulse. And the reason that's important is you can reduce the risk of progression in these second non-involved good eyes in two ways. You can reduce the risk of progression of the dry macular change by about 50%, and you can reduce the risk of conversion to wet macular degeneration by another 50%. That's a really big number. In medicine, if a treatment works in about a third of cases, we consider that a home run. We have a treatment that's available, has been available now for close to 20 years in MicroPulse laser. And there is nothing, all of the drug trials for doing treatment of geographic atrophy have been miserable failures. And as far as I can tell, there's little on the horizon that's going to change that. Two brief concepts that have been presented in Ophthalmology 2020. The references there by a panel of experts in North America and around the world of iRORA and CRORA. The iRORA simply means an incomplete pigment epithelial atrophy, and the CRORA is much more severe with loss of central vision, almost always 2200 or less with these large geographic patterns. One question I am really interested in collaborating with other people is, can MicroPulse laser reduce the progression to the end stage geographic atrophy? There are some prospective papers that with no control groups that suggest you can make a huge difference. I've also had a intense interest in central serous retinopathy. I have a poster coming up this year at one of the retina meetings, 2021, involving 39 cases. A third of my cases are chronic. Some people have had this condition for 8, 9, 10 years. Many more have had it for 5 to 6 months. And nobody's offered them any treatment. You know, the classic story of let's wait till it gets better. Well, it doesn't get better. The vision stays damaged. There's no hope of reducing the fluid and saving the vision that is left. These cases are tough. The fluid will go away slowly. With treatment, it takes probably up to a year to get rid of most of it. And at that stage, I continue the treatment to maintain the rescue. The really interesting group are the acute cases, which are 2/3 of my patients. Almost all of these are young folks. Many are professionals. Photographers seem to be common. And they complain bitterly of the relative scotoma that's caused by central serous fluid. 95% resolve by 3 months after MicroPulse. Patients have reported to me that the resolution begins around a month. I see, in the early days, I was seeing them back in a month because I was curious to know how much the fluid had reduced. The slide you see now is a mechanic at Luke Air Force Base locally, and he presented with a rather large patch of subretinal fluid in a central serous and a tiny pinpoint leak you can see on the fluorescein. There's kind of diffuse damage on the ICG, difficult to know precisely what this means. When I saw him back at 3 months, he had actually been posted to a non-North American base for a few months, and it was a bit later when I saw him. The fluid had resolved in the fovea. He was dramatically happy. There's a small little patch of fluid that you can see there, which is insignificant. It's not in the fovea, and the leak pattern has stopped completely on the fluorescein. Excuse me. The last concept, or close to the last concept I wanted to present, is I've looked at 200 patients in the past year. One group of my own patients had injection with anti-VEGF. All patients had quarterly MicroPulse laser. And the number of injections required for this group to maintain stability was 3.5. Many cases cease injections with laser alone. That's approximately 20% again. Group 2 was from one of my colleagues. He does not do very many MicroPulse, and he's a big time injector, probably does 60, 70 injections a day. And his patients, the same 100 patients, age matched, et cetera. Retrospective chart review. Vision was actually similar on average in both groups. Interestingly, the group with injection only had more loss of reading vision than the group with laser. Not significant, perhaps, in terms of statistics. These numbers are small. We'd probably need closer to 1,000 in each group, or 500 if that's possible. But certainly very interesting. There's a dramatic drop in injections necessary. Dry AMD, the second eye of those with wet, very important. If I see patients with significant findings on the OCT of damage to the pigment cells and symptoms, and the angiogram here shows some scattered changes at the pigment epithelial cells, the ICG is probably unremarkable. These patients will have a good response again to MicroPulse laser. You do the quarterly treatments. All patients are told that this is a treatment that is well established. There's a huge safety factor, as others have pointed out, and there really is no downside. The worst thing that could happen is it doesn't work. And again, about 50% will experience a dramatic decrease in the progression. So that's my slides and what I wanted to point out. And I think at the end we'll be entertaining questions, or if the moderator chooses anytime. Thank you.
Well, actually, Dr. Horstman, I do have a couple questions. Dr. Calzada here. I am particularly interested in your experience with central serous retinopathy.
Yes.
Because, and I'm curious what Dr. Yu handles it, but it's interesting because in central serous retinopathy, we've had this surge of people supporting pharmacological therapy with the eplerenone and all these things. And we are now going back to away from eplerenone, even though some people are still suggesting that we should. But I still have an old PDT laser, and I love my PDT laser when I do it in CSR, but there's a couple of things I worry. I worry that my PDT laser will eventually break down and nobody's going to fix it. and the other one is getting the payment for the purchasing of the Visudyne, because my experience in PDT for central serous retinopathy and for some other conditions, hemangiomas, for example, is fairly good. But it's this issue, this practical issue of the purchasing of the Visudyne and its secondary issues. And again, a laser that once broken may not ever be fixed. So I know about the results of the PACORA group, some of my friends down in Latin America that did a PDT versus MicroPulse experience. And they were actually very happy, and the results are very supportive of MicroPulse. And I'm curious if you do the same sort of pattern, the whole sort of light 500 micron pattern. How do you choose it? Do you depend on ICG? Do you depend on FA? So what's your experience, and more specifically this?
Well, importantly, I treat immediately. I think that's number one. It's taken me 3 years to convince my other colleagues in the group who do not do MicroPulse that if they'd be so kind as to not sit on them for 6 months and send them over immediately. Not because I'm trying to take their patients and get them back eventually when things are settled, but if you treat in the acute phase when they have symptoms, and they all have symptoms, they have fluid on OCT, you may or may not see a convincing pattern of leakage, or you certainly will always see heavy staining on fluorescein. ICG is maybe not contributory, but the occasional patient in the 50s, 60s age group, always worry about an occult choroidal net, and I depend on that to pick them up. So treat immediately, same pattern of treatment as my slide showed with the 500 microns, 450 Applications, I would say I spend about 60% of the time in a painting fashion, just slowly applying the laser over the leak points that I can see on the angiogram. You can pop it up on a screen if you want. Most of the time it's fairly visible anyway. And send them home and see them back in 3 months again. If they're not getting better by 6 weeks, I'll ask them to call my chief technician. We'll bring them back for a repeat. That happens very rarely in the acute cases, and not, as I said, not the vast majority resolve. There's no issues with PDT, drug problems of exposure to sunlight and all the other horror stories that go along with PDT. So this has been very successful. The second thing is, if I might just put a plug in. There's 10 of us worldwide that are doing 100, a bit lower. We're at about 35 now, I think, because COVID really messed things up last year. But having said that, probably by next year, those numbers will be ready, and I'm sure it'll be publishable. But that'll show us two issues: what happens to the chronic cases, about a third are chronic, and the acute cases, so 2/3.
Do you see any difference in the choroidal thickness on the OCT?
Sometimes. I mean, to me, I don't really have a correct way of measuring it precisely to give you numbers, but eyeballing it, yes, I think that's real.
Yeah, it's hard with choroidal thickness because the choroidal thickness can improve even as the disease improves. So it's hard to know if it's treatment causing the choroid to thin, and then the disease got better, the disease got better, and the choroid's thinning. One of the questions I saw in the chat to Dr. Horstman is whether do you change. I like the way how you just keep it very simple. You have like the same treatment pattern. Do you find that there's any difference between the different disease, whether you need to change your settings or your pattern? I think that was
Dr. Horstman, before you answer, Dr. Horstman, do you mind pressing the button that says stop sharing? So, because I think we're getting a little delay on the video.
Oh, hang on a second. Let me try to do that.
So, I'm sorry for interrupting, Dr. Yu.
That's all right. Okay. Is that better?
I think it's a little bit better, yes. So okay. I'm sorry, can you re-ask your question, Dr. Yu? I got in the middle.
The question I had was whether you vary your treatment pattern, your treatment, essentially your settings for the different diseases, or you use the same setting throughout.
I use the same settings with one exception. In a diabetic, of which we all have many, I do combinations of, I do a lot of Ozurdex. I do, again, the quarterly MicroPulse. That's been very successful for me. And in diabetics with a lot of damage, I will do more applications. I'll probably do 600 or 700. But I certainly, that's about the only thing that I alter.
Okay. And then
I have, sorry. I was going to say, I have this sort of, I mean, it's my mindset from the laser perspective, and maybe I'll switch to your perspective at some point, Dr. Horstman, but I have this thought of, I don't like treating areas that don't have disease. But I guess your point is that most of these patients have disease all throughout the macula anyway.
I think so. I mean, the angiogram is very helpful in figuring that out. It's astonishing when you really look for and try to determine, and it's subjective, obviously. There's not a good way that I can measure ischemia, but again, when you have a resolution of 5 microns on some of these machines we have today, ischemia is really common. Even in those that have no DME, they've been diabetic for 30 years, and they weigh 300 pounds, they've got every disease in the book, and their vision is like 20, 30. Even those people have ischemia, but the ones we treat obviously are those that have symptoms and fluid, and they're a real challenge. It's a struggle every single day.
And Dr. Yu, you had another question, and yet again I interrupted you.
Yeah, actually, this question is for you, Dr. Calzada. Actually,
bring it on.
You mentioned that you don't like to treat over areas without edema. So do you, because a lot of your cases, and I'll probably segue soon into my section too, because it relates to this, where the edema is kind of focal, do you only treat over the area of the focal
So what
edema?
I usually do is I will do an FA as well. I didn't show the FAs, but I do the FA, and what I'll treat is I'll treat over the area of edema plus whatever area is leaking. And for the most part, those areas overlap, if not completely, maybe a little bit of difference. I've wondered, should I, run a study protocol to understand that better? But in a way, perhaps mirroring Dr. Horstman's perspective is like, I don't feel like I'm damaging anything it's not like it's an over treatment. So perhaps I'm avoiding lasering areas that don't have significant leakage, but I'll treat over leakage and over edema and just do that area. And on that point, I think it's time for introduce Dr. Yu, by the way. Dr. Yu is associate professor at University of California, Davis. And so we have multiple people from all over the United States here, and I would love to see what Dr. Yu has to bring. Thank you for your contribution, Dr. Yu.
Thank you. So so thank you for the introduction. It's interesting that Dr. Calzado was talking about because how he would like to treat over the area of edema as well as the areas of leakage. Personally, I actually treat often over the entire macula because I do believe that the mechanism of action is, I don't see any damage at all. We do multimodal imaging, autofluorescence, infrared. I actually don't see that much any indication of pulse laser treatment causing any damage. And in fact, if the concept is to upregulate these heat shock proteins and kind of in a more neuroprotective manner, I actually find that a broader area of treatment is often useful. So I actually like to treat over the entire macula. But with that, let me just talk about using MicroPulse laser for DME. And one thing that's interesting, I guess the great thing about going last is I have the perspective of both Dr. Calzada and Dr. Horstman to see. And one of the things I find that's interesting is that everybody has very different methods of applying, because that was one of the questions in the chat, like what exactly do you do for what treatment? And the fact that it kind of works for all of us suggests that there is a little bit of variability in terms of how we treat that can still all work. But one thing I know that's very, that all three of us are emphasizing is the density and the large amount of treatments. It's not a laser. It's not just applying a few spots, it's applying broadly over a larger area and often involving through the fovea. What types of patients do I use MicroPulse laser for? I think the best are patients with good visual acuity. This is similar to what Dr. Calzado was talking about in terms of focal macular edema. When prior to the advent of Protocol V, we actually didn't know what to do with a patient with 20/25 vision. Are we supposed to start doing anti-VEGF injections? And I personally, coming from the patient's point of view, if I had 20/20 or 20/25 vision, I don't think I want my doctor coming in with a needle giving me an injection. Whereas if you propose to a patient that you can do a MicroPulse laser or some type of laser therapy that could prevent, delay, or even prevent the worsening of edema and maintain their good vision, I find that they're much more amenable to it. And in fact, one of the studies that I started, when I came to UC Davis, Larry Morris, one of my predecessors, was a big user of MicroPulse. And I came from a training program that didn't do any MicroPulse lasers, so I didn't know how to use it. One of the questions, obviously, a lot of people ask is there's no data. So there is currently, we are starting a clinical trial right now where we're looking at patients with good visual acuity, and they're randomized to MicroPulse laser versus sham. And the results are ongoing, but I definitely already, as I'm applying it to my patients, can see the beneficial effect. Patients are very open to the idea of doing this type of laser treatment. It does not commit them to injections. I think many people think once they're committed to an injection, they're kind of getting injections forever. You don't know what your endpoint is. Whereas the MicroPulse laser, I feel like that is because you can repeat it easily without the need for injections. I think patients are much more open to it. When the Protocol V results came out, I was actually a little worried that it would show that you have to start giving anti-VEGF injections at 20/20, and I would actually block my study from moving on. But indeed, according to trial, you can wait. If you have people with good visual acuity and center involving DME, you can still wait. And so for me, those are the perfect opportunity to try to apply MicroPulse laser. Number one, it lets the patient feel like something's being done. Number two, I think it also might have them kind of follow up closely to see what the results are like. And number three, I definitely do see many patients that will improve over time with the treatment. So I think in addition to observation being an option for these patients, MicroPulse laser is excellent. The second is exactly what was previously mentioned, is non-center involving DME. Historically, we would do focal laser for this, but with the advent of MicroPulse laser and the fact that we don't see actual scarring that occurs resulting from it, I think it's much more compelling to use as a treatment therapy. And I kind of group these along with patients with good visual acuity too. Again, they're 20/20, 20/25 vision, and I think these people benefit the most from this treatment. The last group are diabetics who require frequent injections. And this is kind of at the other end of the spectrum. You have the people who benefit clearly from anti-VEGF. You need rapid response because their vision just got worse with center involving edema. But then on the two ends of the spectrum, you have the people with good visual acuity. You can use MicroPulse almost as a preventative measure. But at the other end, you have the people who you keep getting injections and injections and injections, and it seems like there's still residual edema. Historically, we would usually start looking at other kind of second line, third line treatments like steroids. But particularly, I find many of my patients are a little concerned about things like cataracts, glaucoma, or pressure steroid-induced IOP elevations. And for those people, MicroPulse definitely has a benefit. One of the studies that we published a few years ago was one of our fellows did a case control study looking at, because my practice is variable number of patient treatment patterns between providers. Some providers use MicroPulse more frequently. So we compared a case control series with patients who were receiving anti-VEGF injections for diabetic macular edema with or without MicroPulse laser as an adjunct therapy. Now, if you look at their visual acuity, across the board, visual acuity of those that had the MicroPulse were slightly better. We actually don't think that this is a real, because the baseline vision were similar. So I think that they were just not perfectly matched in terms of their baseline vision. I don't think that it necessarily gave you better improvement in vision. But what we do see, however, is the much smaller number of average injections received over 12 months and or longer in those that were also getting MicroPulse laser therapy. So here's a clinical example of some of what I've described. Here's a patient who's got 20/25 vision, some perifoveal edema, not center involving, and it was 20/25 vision. So again, according to protocol V, you don't need to do an injection at this point, but we felt like something should be done. So we did MicroPulse laser. What's interesting is when you first look at it, many of us kind of quickly glance at a foveal B scan. You're like, oh, I'm not super impressed. The vision's about the same. He held out his vision for about a little less than a year. But if you look on the actual map, you can see that actually much of the edema has improved. And this also is kind of a good reminder for those of us who are in a busy clinic. It's important to go through the entire scan, the entire volume, and look through all the different scans. In terms of treatment, I actually am a big fan of the Texcel, the grid pattern. I think it significantly reduces the amount of time. I think it's perfect application for MicroPulse laser because it can allow you high density packed spots you don't have to worry about, because you don't see that graying that you see with traditional continuous wave laser. It's sometimes hard to line them up. So like, did I move too much of a space? Did I treat right? Like, how far was I? Whereas here, because I'm essentially applying only 8 spots of, each of them are 49 spots in it, I don't have to worry as much about too much overlap, too little overlap, too spread out or not. I actually historically have treated through the fovea. As part of our clinical trial, because of IRB and safety issues, we just wanted to not have to deal with concerns about it. So we actually exclude the foveal treatment, although for my patients that are not part of the clinical trial we're running, we actually often will treat through the fovea. We found that again, some of our methods have changed over time. Historically, I actually did exactly what Dr. Horstman did, which is to use a standard wave power. We land around 400 milliwatts or so. I think Dr. Horstman mentioned about 500 milliwatts. It might vary depending on different population of patients and whether, the diversity and how pigmented patients are. But I find that even when you do titration, oftentimes we end up around the same range anyway. So I think it's helpful for at least for our clinical trial that we want it to be absolutely safe and we have this whole titration method. But I think in normal clinical practice, as Dr. Horstman said, I think it's great to just stick with a general number that you can use on everyone. But at least for most of our patients currently, I kind of like to standardize things with our protocol. We do 200 micron spots in continuous wave to do a test spot outside the macula, 200 milliseconds. We titrate starting at 50 milliwatts and increase by 10 milliwatt increments until we get just a bare burn. Then we actually switch to quadruple that power and then to 5% duty cycle. So it ends up usually around the 400 to 500 milliwatts range. So it's kind of similar to what Dr. Horstman mentioned earlier. And then I think we do another single spot again, just to make sure since you're about to apply 49 spots in rapid succession, we do the one spot outside the macula as well, just in that MicroPulse mode to make sure you're not creating a burn. And then we'll switch to the 7x7 grid with 0 spot spacing. And it goes really, really quickly. I mentioned here, we may or may not include the foveal region. I think that it's, I think particularly with the concept in mind of what the mechanism of action is, which is to increase the heat shock proteins and to improve the survival of the neuronal cells in the neurosensory retina. There's no disadvantage to treating in areas that do not have edema. Here's some additional examples. Again, an extrafoveal good vision macular edema. After a few months, you can see the edema improve. And here's another example of one that, again, at least at one area where the vision, where the edema improves quite a bit. So again, this is kind of my general treatment paradigm. I have not personally used it for central serous or AMD, although I'm intrigued by Dr. Horstman's presentation. I'd love to, I think that it is definitely an unmet need, both for central serous, now that we don't have, the Vici trial, as Dr. Calzada mentioned, demonstrated no improvement with eplerenone. For those patients who want, good vision more quickly, as well as patients with AMD, maybe intermediate AMD, potentially preventing them to progressing to geographic atrophy. I think that I'd love to start 3 more trials on this, but my bandwidth is limited. I'd love to hear from the audience and as well as my other panelists, any questions on how we apply it. But I've definitely fallen in love with using the MicroPulse laser platform for these diabetic macular edema cases.
I find, Dr. Yu, very interesting how your perspective and my perspective coming around, we end up in a very similar spot. And as you mentioned out, how Dr. Horstman, you and I there's some common patterns into the patterned application that we have, which is treat more rather than less. Number one, use a tight confluence of your therapy. So Dr. Horstman uses a broad area, but it applies everywhere in that area. You and me, even though we use different grid sizes, you still apply the same no spots intervening zero spot spacing. So I think that's very interesting. And could you go back to your presentation? I want to emphasize something you said, which I think is very interesting. And if you can put like the series images that you have on the map, and I think Dr. Yu hit something that it was in a way apparent in the background. yet not obvious to most of us as we're doing is that we're all of us looking at maps. And I will tell you, prior to using MicroPulse laser, I was not looking at maps as much as I was before. And so now I'm using maps because it's, in my opinion, the only real way to understand this. Now, from a purely statistical perspective, and Dr. Yu is the academician of the team, doing a statistical analysis of map height is exceedingly difficult. Now, that's one of the reasons on a lot of the studies on that you see, it's mostly measured centrofoveal thickness or different measures of that, because it's a single number that you can clearly track over time. But in this situation, if you try to look at the whole macular volume over time, it's a number that doesn't change that much because you've got a focalized edema. So the statistics of this image analysis are very, very complex. But interestingly enough, it's pretty obvious when you see it. Like it's well, you don't need numbers to see that clear determination of changes. So I think that's important that we're moving to looking at these in these patients. The other part that I was gonna point out, if you see on your image on the right on the 3317, you will see your little hyper reflectant spots on the infrared that I see on my patients, that I am convinced means that we did something. Now, I agree with you. They don't mean damage, but I find that as a signal of biological effect that to me makes me realize that we are changing something objectively. It may be subtle, but it's there. And I've learned to see those on the infrareds and say, oh, I did a MicroPulse on this patient. I go back in the chart and realize that I did. So it's just a little point. Now, I want to ask a question to both panelists, because there's one condition that we didn't discuss much, which is retinal vein occlusions. And Dr. Yu, since you're here with us right now, do you see a difference in responsive MicroPulse in in vein occlusions versus in diabetes?
My personal feeling is that in general, it's I tend to use MicroPulse for diabetic macular edema. There actually are literature on using MicroPulse for RVO with macular edema, particularly in terms of reducing the amount of injections. I think Ted Lang had a series. I think he did a number of studies, actually. The question, I think, is the pathophysiology is different. I think diabetic macular edema itself, the disease fluctuates, whereas the vein occlusion, there's like an acute event, and then everything kind of follows after that. So generally, I have a stronger tendency to initiate anti-VEGF therapy for retinal vein occlusion. And I tend to just kind of taper off and reduce I just kind of do a treat and extend. So I kind of stack them up front and then extend over time. I have not tried using MicroPulse laser to try to see if they would reduce the frequency over time. But I'm a relatively new user compared to Dr. Horstman. So it is another thing I'm intrigued about. I think now that I'm doing my clinical trial, I'm hoping that it will, if the results are positive, I'd love to expand it to other different diseases.
I have been using it for vein occlusions, but frankly, less than for diabetes. And just as you pointed out, I don't see these dramatic results. I think they require statistics, as I said.
Well, I think it's, there's an acute ischemic event, right? And then you're also potentially limited by macular ischemia. I love the idea of treating these people with relatively good vision, because I think, as I mentioned, people with good vision don't want a needle in the eye. So I think that it's easier to convince them. Whereas people with very severe disease and center involving disease, we can just do an injection. But I think the other advantage, I think, is that you can, particularly with diabetic macular edema, is that there's a good experience already with focal laser. So I think it's a lower threshold to try to treat.
Yeah, I find the psychology that you mentioned very true. It happens on my patients as well. The only patients that I find that have reticence of proceeding to a laser are those that were, these older patients that had these dense BRPs and macular grids from back in the 90s. And they say, please, no not
No
laser.
more laser.
Yeah, and those are the only patients that I find that would rather not do this. I'm curious if you could stop sharing so we ask Dr. Horstman the same question about RVOs. Dr. Horstman,
Yes.
what's your perspective on retinal vein occlusions?
Well, a less happy experience to be certain, and I think that Dr. Yu's point of ischemia is precise and very, very critical. Those that are highly ischemic respond to nothing. It's a disaster. I do treat with anti-VEGFs. I quickly move to Ozurdex. If they drop down to 2100, I'm thrilled, and we have reasonable control of their swelling. I do MicroPulse on these patients again quarterly. It seems to have become an addiction for me over the past 5 years. My numbers have skyrocketed the past 2 years. The really exciting group here in the vein occlusions, I saw one today. 62-year-old guy, plays golf 5 times a week, relatively healthy, doesn't take any meds. Goes in at 20/40 vision with difficult to assess the ischemia because there's too much hemorrhage, but his fovea is just minimally involved on the edge. I gave him an Avastin today. I'll bring him back in a couple of weeks for MicroPulse. And my prediction is, because I've seen this time and again, he will end up needing no more injections until maybe 6 months. The MicroPulse will hold him at possibly some low-lying edema, but his vision will stabilize at 20/30, and as the blood clears, he'll stay there. And very few of those progress to the disastrous ischemic events. But the average patient that comes in at 2200, it's a very unhappy experience for all of us.
I think it's wonderful, Dr. Horstman. Any other comments, Dr. Yu, about other conditions or the discussions that we've had?
The only other point I want to make is that I think when we're so used to just doing Snellen visual acuity or ETDR as visual acuity, and there are many patients that do have visual impairment even with 20/20 vision. And one of the things we're looking very closely at are things like microperimetry, low luminance visual acuity, contrast sensitivity, and all of those in patients with 20/20 vision DME actually show significant impairment in that.
Absolutely.
So that's one of the areas where I think MicroPulse is going to be will shine, is that it's probably going to show us benefits in areas that we didn't expect to look, which would be just central subfield thickness and visual acuity.
Yeah. Somebody asked if you could explain the reason that you do the continuous wave test pod. So I was going to ask that question because I do my test pod with MicroPulse because I'm thinking I'm using what I'm using, but you do a continuous wave, but then you still try to see how it responds with the MicroPulse in the arcades or outside the arcades.
I was just in the middle of typing that answer. Yeah, so we titrate the power to just barely visible without MicroPulse, and then we quadruple that power, then switch to MicroPulse, then apply another spot. And then because the concept there is that there might be some variability in terms of people's pigmentation that would require different powers. Although, as I mentioned, ultimately, maybe because our patients are generally similar in terms of race, it all ends up around 400 to 500 range. So it's not that big a difference.
It's interesting because all three of us have different ways to select our powers and ours, but we end up nearly about the same sort of, 4, 5, 6, 700 micro milliwatts. So that's an interesting question. So there's another question here about pigment epithelial detachments, if they can be treated with MicroPulse laser. I think the question, pigment epithelial detachments, always comes down to etiology. Like, because when you talk about pigment epithelial detachments, are we talking about central serous? Are we talking about macular degeneration? Are we talking about, what condition? And I think that question about epithelial detachments, to me, really depends on the underlying condition. Now, Dr. Horstman certainly has more experience with multiple conditions that have epithelial detachments as a common sort of finding. But I think in terms of treating only for the epithelial detachment, I'm not sure unless Dr. Horstman, I have done PDT once on a patient with CSR that had no subretinal fluid, but had such a massive pigment epithelial detachment that the patient had metamorphopsias, like significant metamorphopsias. I did PDT on him, the pigment epithelial detachment flattened, and he loved me because his metamorphopsis decreased, but that's the only one that I've done without subretinal fluid. Have you done MicroPulse on epithelial detachments without subretinal fluid? Dr. Horstman.
Yes, excuse me. Again, PEDs are an unhappy experience. If I'm convinced they're serous, I leave them alone. We've known for a long time that if you succeed in flattening the PED, you end up with geographic atrophy. That's a really unhappy experience. So I tend to stay away from them. We all know of those that have a pigment epithelial rip, and sure as the day will occur tomorrow and the sun rises, you will get 1 in 1,000 that will rip the day after you do your MicroPulse, and you will have an unhappy patient calling you 10 times a day. That's never happened to me, of course, right? Sure. And your comment about the 1990s heavy laser, I plead the fifth on this. I mean, I was involved in all that stuff, so I don't know why you're picking on me because I don't have any hair left.
So there's a question about cystoid macular edema and uveitic cases. Now, my personal opinion is that in uveitis, I treat the cystoid macular edema pharmacologically. Because what you have, in my opinion, in those cases, is the breakdown of the blood-retinal barrier from an inflammatory condition. And I think you need to treat the inflammatory case. Now, there's certain patients with uveitis that will have secondary vascular occlusion, secondary vascular pathology, which may consider, but I don't think that MicroPulse is the way to go on uveitic cystoid macular edema. Do you have any comments on that, Dr. Yu, Dr. Horstman?
I think you're right. Yeah, you're right.
Yeah, you treat the underlying inflammation, which is
you treat the underlying inflammation, and you can treat pharmacologically the overlying edema sometimes if you have to. But I think that's more of a treatment for the underlying condition. What other conditions? Could we have a couple more minutes? What other conditions do you think we haven't covered yet? We've covered CSR, we covered diabetes, we covered vein occlusions.
Well, there's one thing, if I may jump in. I have a case, 21-year-old optic pit patient. He's got a large detachment of the macula, and I've only done one treatment yet. I saw him back once, hadn't changed very much yet. It was kind of deflated. There's one case in the literature that responded, but it took 6 months. So we're not sure whether it's time that fixed it or the laser, but it's at least a relatively harmless treatment versus going to vitrectomy.
Yeah. And one last question for everybody, because there's a repeating question about the severity of the macular edema in terms of thickness. And meaning, is there a point where you treat with anti-VEGF based on the height of the edema? And I think based on what I'm hearing, if the fovea is involved, I will treat with anti-VEGF, particularly if you have significant vision loss from fovea involved. And if there's a little foveal cyst, it's 20 good vision, yeah, I'm okay doing MicroPulse. But if the fovea is involved, I think there's multiple reasons for that, but I think the most important for me is about time. Because MicroPulse, even though we've shown that it works, it doesn't work over the course of weeks, it works over the course of months. And when you have the fovea involved, you want to dry it out as fast as possible, and that's where your pharmacological therapy shines. But in terms of the height, I've shown on one of the cases I showed had over 500 micron elevation on a focalized location that responded with MicroPulse. So it's really not about height; it's about diffuseness or involvement, particularly of the fovea.
Yeah,
any questions on that? Yeah.
Yeah, you definitely make a really good point, because I think one thing about MicroPulse laser is that you actually have to be quite patient. Even if there is center involving, I don't treat it for large amount of center involving. Again, for usually small amount of center involving. Sometimes it could even actually get worse in the first few weeks. And sometimes when you look back, like within the first 2 to 3 weeks, you're like, oh, did things get worse? But then it's usually over the course of 2 to 3 months that you actually see the edema improve. So I think the key is to be patient and not to immediately jump to conclusions after just a few weeks.
I agree. To that same point, I've been burnt before on a patient that I'm doing repeated anti-VEGF injections, and I see improvement, and then I say, okay, I'm going to do a MicroPulse now, and I hold off on that injection, and then they come back a month later worsened because the MicroPulse hasn't caught up and the vascular disease is still ongoing. So I think you need to understand the kinetics of this sort of, it works, but it doesn't work in a month. It takes 3, 4, 5, 6 months in certain patients, and it's a progressive sort of decrease. So wonderful, guys. Everybody, with a green laser, would you change any parameters or use it with some pathology? I mean, I think most of us use the 577, which is a yellow laser. What do you guys do with 532 green laser?
Same settings.
I don't use the green for MicroPulse.
Okay. Well,
I don't
wonderful,
use it
guys.
either, but excuse me, I'm sorry. I don't use
Please,
it either, but I've gone over this with many people that I consider experts worldwide, and the founders of this technology, of which there are several people, all agree that it doesn't matter the wavelength. Some people are really aggressive about using 810, and again, it doesn't make any difference. You have to respect the parameters, understand what you're doing, and to whom it apply it. But the laser wavelength is not a material issue here.
Interesting. I think that's very interesting. Do we have any more questions to answer? I think, are you seeing a decrease in medication caused by injections in your practice by using MicroPulse as an adjunct to injections? And the question is for both of you guys, and I'm going to go ahead and say yes.
Yes.
But,
Yes.
In the last question, do areas of severe thickening require higher intensity of MicroPulse? No. I think we're doing if you notice, all of us are doing our sort of gradation of therapy, but we do not increase the power because an area is more swollen than another area. We basically, once we choose a power, and Dr. Horstman has a standard power, Dr. Ewan and I go about it a different way, but once we go with it, we just go with it and not increase it to an area of higher thickness.
Yeah, it's almost more just the density and the large area of treatment is more important than the actual, almost like the specific power in settings.
Absolutely. And besides, we're not really treating the retina. We're treating the underneath the retina. So the amount of thickness doesn't have anything to do with the optic that you're applying. So well, wonderful. I think we've had a wonderful experience, and I think Dr. You and Dr. Horstman, thank you very much. And I think we've shared different experiences from across the United States, and I think we've landed on some very interesting sort of generalities, and I appreciate it. And I want to
Thank you very much.
Yeah.